Greetings and a warm welcome to everyone. I'm Shreyushi, the assigned moderator from Clirnet. It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform Clirnet. It stands as one of the largest live digital CME platforms in India, providing a space for doctors to create and share medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Amitabh Banerjee sir. Sir holds degrees in MBBS, MD, postdoctoral epidemiology from Dr. D.Y. Patil Medical College, Pune. Sir is Chief Editor, Medical Journal at D.Y. Patil Vidyapit and Academic Editor, plus one. And today, sir will be talking on the topic approach to diarrhea. So, without much delay, I would like to hand over the session to you, sir. Please proceed with the talk, sir. Over to you.
Thank you, Sayasri. It's a pleasure to come on the Clirnet platform, and I extend my greetings to all my colleagues. Today topic is an important one, particularly from child health angle, because we are losing a large number of children due to diarrhea, and it's a major cause of infant mortality and under five mortality. Of course, adults are also affected, but the main brunt is borne by children. So we will be discussing the approach to diarrhea, how the clinical approach, the little about the epidemiology, what are the causative agents, how do you manage diarrhea, because it's very important to manage diarrhea by rehydration. The seat anchor of treatment is rehydration, and then what are the preventive measures. So this would be the scope of the session, the definition and burden, when to use oral parenteral fluids and what solutions to use. There are certain restrictions, particularly in a severely malnourished child, severe acute malnutrition. There we have to be careful about the sodium load and the fluid load. So we have to take special care in some children who are very malnourished. Then, as I said, identify the malnourished child and adjust management accordingly. We'll discuss this in some detail. When antibiotic treatment is indicated, it is very rarely indicated, and the adverse effects of overuse of antibiotics. So diarrhea, I want to emphasize, take home message is rehydration, and antibiotics have a very little role, if any. And another important thing is there is a role of zinc in acute diarrhea. This has been there for quite some time, and then the prevention and control. So this would be the scope. So definition of acute diarrhea is lose watery stools 3 times or more in 24 hours. So history is most important when you approach a patient of diarrhea. The patient is having, you have the parents, if it's an adult, ask the patient what is the frequency, whether the stools are loose, consistency, and the frequency more than 3 times in the 24 hours. It may go very high, 10 times, 50 times, then it's severe dehydration. And then the duration. If it is more than 14 days, then it is chronic diarrhea. Then you have to look for other causes like immune deficiency, HIV, other. But today we'll be restricting ourselves to acute diarrhea, and mostly in children. In the breastfed infant, the diagnosis is based on a change in usual stool frequency and consistency as reported by the mother. Breastfed babies, they fast more frequent stools, but if the breastfed baby is having more, the mother will know than the baseline. And if a child is exclusively breastfed, there are very little chances that he or she should suffer from diarrhea. If the hygiene is maintained and no first 6 months is exclusively breastfed. Mostly it comes, the diarrhea in children during the weaning period after 6 months when solid food is introduced. So this is the burden. This just to give an overview of the burden. The diarrhea can be prevented. There are 2 billion cases every year and 1 million deaths all over the world. So this is the highest cause after pneumonia. Pneumonia is the number one cause. And after pneumonia, the diarrhea, this is the circle, that is the yellow circle, that 17% of deaths in children are due to diarrhea. And here it has mentioned about 50 Almost a million. Here it is almost mentioning half a million, but it is a estimate if you child deaths, but if you consider the total deaths, and 80% of these deaths are occurring in Africa and South Asia. Unfortunately, India has the highest number of child deaths. Nigeria is the second. Nigeria diarrhea causes over 1 lakh deaths of children under 5 years, the second highest rates in the world after India, where, of course, we have a very large population, many times larger than Nigeria. We are losing 3 lakh children a year to diarrhea. So this can give you an idea that, and it is, the deaths are easily preventable. The disease, the diarrhea may take some more improvement in living conditions, particularly water supply and sanitation, but deaths are preventable by oral rehydration. And we have done our own surveys, and we will be showing you some data from large meta-analysis where less than 50% mothers give ORS at the home. Oral fluids can be given and it can prevent deaths. So this awareness is very important. So this is the, and what are the major agent, host, and environment? The familiar epidemiological triad, as we call, there are number of diarrheal pathogens, viruses mostly, and even bacteria and parasites in tropical countries. Amoebiasis is one in tropical countries, then helminthiasis that are, but mostly it is virus and pathogens and food poisoning organisms. Then host factors are very important, particularly in the malnourished child. They are more prone to infections because of less immunity. So the vicious cycle is there, and of course the environmental factors. That is the water supply, crowding, personal hygiene. All these are the ways to prevent also, whether you can attack the agent. Agents are many, so piecemeal attack on agents will not bring down the rates of diarrhea. You see, we have got a rotavirus vaccine. It has not brought down the diarrheal deaths because it is only one piecemeal solution. There are many viruses, many bacteria. If you improve the water supply, all the pathogens are eliminated. So that will be the single common prevention method. So these are the clinical types, as I had said, two main clinical types, acute watery diarrhea and acute bloody diarrhea. They may be frequent loose stools, watery stools, and without blood. That is diarrhea. If there is blood, then it is bloody diarrhea. It is called dysentery. Acute bloody diarrhea means dysentery, and the most important organisms are Shigella dysentery, which can cause severe bloody diarrhea, and it has got a potential for outbreaks also. So that's why we have to be very careful to exclude Shigella, and of course, occasionally Entamoeba histolytica, as was amoebiasis. So bloody diarrhea, we have to think of Shigella and others. This rotavirus is mostly watery diarrhea in children. Then E. coli, Vibrio cholera. Vibrio cholera, the classical ones, used to have a very typical presentation. It is rice water stools. The diarrhea used to resemble rice water and very frequent, and projectile vomiting. Vomiting, and patient used to go into severe dehydration very fast. That was many epidemics, and even now in the sub-Sahara belt, we are having cholera epidemics. Fortunately, in many parts of the country, we are having cholera, but they are due to the Eltor variety, which is less severe. So Eltor is gradually replacing the classical cholera, so you may not get the classical symptoms, signs and symptoms of cholera like rice water, stools and projectile vomiting, but still it is always we have to be on our guard against, because cholera also has got epidemic potential, outbreak potential like Shigella. Bloody diarrhea, most episodes are due to Shigella. The diagnosis signs of dysentery are frequent loose stools with visible red blood. Other findings in the history of an examination may include abdominal pain, that is again bacterial diarrhea and Shigella. There will be tenesmus, pain after fever. Fever is there in bacterial diarrhea. Convulsions, the child, lethargy, dehydration, and rectal prolapse. Bloody diarrhea. So they are more severe. These all children with severe dysentery require antibiotic treatment for 5 days. So mostly Antibiotics are not required, but if it is a dysentery, because the causes may be bacterial, and even for amoebic dysentery, you require antibiotics. In addition to metronidazole and tinidazole, antibiotics are required for amoebiasis also, as well as shigellosis. Oral antibiotic, which must most strains of Shigella, you should have some sensitivity reports also from the lab. Examples of antibiotic Shigella strains can be sensitive are ciprofloxacin and others. Fluoroquinolones also manage dehydration. Dehydration in all dysentery or diarrhea should be always taken care of. Breastfeeding should be continued in a child, and normal diet for older children follow up the child. This is another problem. Children and even adults, if they have diarrhea, they stop taking even fluids, they stop taking even food also, thinking that, but little food is absorbed, so it will help in faster recovery. Even if the frequency of stools increase, if a person is having food, he or she will recover faster. And the fluid management, this is a challenging. In a normal child, you give a ORS, that's okay, but a severe acute malnutrition may not be able to take orally. And if the diarrhea is also severe, it is challenging. Dehydration is difficult to diagnose in severe acute malnutrition. The child SAM, severe acute malnutrition, and it's often overdiagnosed because the skin is loose. How do you, one of the sign of dehydration is when you try to pinch the skin, loose skin of the abdomen, it goes back slowly. Otherwise, the elasticity is decreased in the skin. And diarrhea, if the dehydration is there. Besides the sunken eyes, dry eyes, no tears, and the tongue is also dry. And but in a severe acute malnutrition, you may overdiagnose dehydration. And the pathophysiology mechanisms of fluid management is slightly different in severe acute malnutrition. Even if the sodium may be low, total body sodium is often increased due to increased sodium inside cells. This is in severe acute malnutrition. Additionally, sodium in extracellular fluid if there is nutritional edema. So the sodium is already overloaded in other compartments. Reduced excretion of sodium by the kidneys, urine output is reduced. So cardiac function is impaired in severe acute malnutrition. In such cases, treatment with IV fluids can result in deaths from sodium overload and heart failure. So we have to be very careful. So the correct management is reduced sodium oral rehydration fluid given by mouth or nasogastric tube if necessary. The volume and rate of oral rehydration fluid are much less for malnourished than well-nourished children. See next slide. IV fluids should be used only to treat shock in children with severe acute malnutrition who are also lethargic or have lost consciousness. So we may require the services of a pediatrician, or if a general practitioner is giving rehydration, one should be very careful with a severe acute malnourished child. So assessment of nutritional status is also important because you have to exclude severe acute malnutrition. So weight for age, different charts are there, road to health charts, and it is important to exclude severe acute malnutrition because the severe acute malnutrition child, as I said, so increased sodium intake can result, we have already discussed, additional sodium and extra, again we have discussed. So all these are that's why we have to do the child nutritional assessment. So these are the ways of nutrition assessment: weight for age and the mid-arm circumference, visible signs of wasting. So sometimes the severe acute malnourished child, very obvious. The child is malnourished, it is very obvious. Weight also is a very objective. Angular stomatitis, there may be multiple deficiencies, and diarrhea is just one aspect, but acute saving the child from dehydration is important, as well as for other airway, breathing, other things, vital signs. Nutritional edema, anthropometry, and all that are routine practice in pediatrics. So these are the mid-arm circumference. So different nowadays softwares are available. WHO charts are there. Softwares are there where you just measure and put, and you can come to know how malnourished the child is. Or so dehydration reduces weight. Dehydration. These are some of the lab investigations Acute diarrhea is usually self-limiting and investigations to identify infectious agents are usually not required. But as I said, if there's a bloody diarrhea or if there's a rice water stool suspecting two pathogens like Vibrio cholera or Shigella, you require lab confirmation. Blood or mucus in the stool and high fever. High fever may be due to shigellosis. High fever can be also due to salmonellosis. That is a food poisoning agent. Salmonella is a rodent contamination, storehouses, cookhouses. So the salmonella can be due to excreta of rodents or other animals can cause salmonellosis. It's a zoonosis. It can cause fever. Septicemic illness and diagnosis if the acute diarrhea is uncertain. Indications for measurement of urea and electrolytes are the severe dehydration and shock. Children on IV fluids should be monitored electrolytes. Children with severe acute malnutrition, you have to continuously monitor the sodium and other levels. Suspected cases of hypernatremia dehydration. So you should not do sodium, uh, you should not overload with sodium also, or even with fluids also. Rational use of antibiotics. Even though bacterial pathogens are the commonest cause of acute diarrhea in developing countries, there should be caution and rational use of antibiotics to discourage development of microbial resistance, avoid side effects and reduce cost. For example, though we say that bacterial diarrhea, you may give antibiotics. Shigella, of course, it may be indicated, but say salmonellosis, it's a bacterial diarrhea. But they have found studies that if you give antibiotics, the duration of carrier stage, it does not reduce the severity of salmonella diarrhea. Salmonella typhimurium, that is a food poisoning organism, not the Salmonella typhi. Salmonella typhimurium, which causes the diarrhea, acute diarrhea with fever. So there, if you give antibiotics, there is not much benefit, and on the other hand, the carrier stage is prolonged. So that is one aspect. But that usually we overuse antibiotics. Antibiotics should be used for severe invasive bacterial diarrhea, as a shigellosis. Cholera, it has got tetracycline they used to give, but again, it has got a secondary role. We can give doxycycline, tetracycline. Giardiasis, of course, like amoebiasis, you give tinidazole, and of course, tetracycline and doxycycline, some antibiotic plus anti-amoebic. Suspected or proven sepsis and immunocompromised children. And antibiotics are contraindicated specifically in E. coli O157H7 because they increase the risk of hemolytic uremic syndrome, HUS. This is a very severe type of E. coli 0157H7, uncomplicated salmonella and enteritis because they prolong the bacteria shedding, as I said, the carrier state. So specifically contraindicated in E. coli 0157, which can cause very severe, which is due to contaminated beef or meat products in manufacture. The E. coli 0157 H7, there is one novel also, Robin Cook's, where they have described this. I'm forgetting the name, but the author is Robin Cook. Zinc and diarrhea. This is one important development. Of course, not very recent. I mean, we know it for decades. Zinc deficiency is common in developing countries, and zinc is lost during diarrhea. Zinc deficiency is associated with impaired electrolyte and water absorption, decreased breast border enzyme activity, and impaired cellular and humoral immunity. So, zinc is important after oral rehydration. Zinc treatment with zinc reduces the duration and severity of acute diarrhea and also reduces the frequency of further episodes during the subsequent 2-3 months. So WHO recommends that children from developing countries with diarrhea be given zinc for 10 to 14 days. The dose is 10 milligram daily for children below 6 months and 20 milligram daily for children above 6 months. For 2 to 3 weeks, one should give to prevent recurrence and recovery and to prevent recurrence. Then we come to the how we do prevent the diarrheal diseases because this what happens is you treat an episode, the child goes back into the same surroundings. So there is a recurrence. So if the overall environment, hygiene, water supply is not there, a child in a developing country continues to have 3 to 4 to 5 episodes of diarrhea in a year. Every 2 months, the child gets diarrhea. And with each episodes, the malnutrition increases, absorption decreases, malnutrition increases, and that again makes the child susceptible to diarrhea because of lower immunity due to malnutrition. And then the protein energy malnutrition, then the under 5 stunting and other things. So it's a vicious cycle. It's not one isolated thing. Everything is interconnected. So this primary prevention, the long term, short term is saving the life from dehydration and other complication. Long term is important because the child will get the frequent episodes. The primary prevention is to reduce the disease transmission. There is a vaccine available for rotavirus, but as I said, the rotavirus vaccine as on today has got less than 50% efficacy. So it doesn't make much an impact. And it will prevent only diarrhea due to rotavirus. It doesn't have any. So, okay, that is there. And of course, measles vaccination is important in children because measles disease itself, respiratory disease, measles has got high mortality in the undernourished child, firstly. Secondly, measles predisposes to diarrhea because it affects the epithelium of the intestine and vice versa. A malnourished child is more affected by measles. The mortality of measles is higher in the undernourished child. And measles recovery, one of the complications can be diarrhea. So measles vaccine is important. And of course, overall hand washing with soap, particularly mothers, parents, children, they hand washing, they have done studies, just availability of plenty of water and soap can bring down the incidence of diarrhea and child deaths also. So these are again a challenge in slums and all. There is a shortage of water supply, particularly in the summers. Water is not available even in many societies also. So there is hygiene is adversely affected. So that is one. So adequate and safe drinking water. Unfortunately, nowadays everybody is going for bottled water, but good public health demands that tap water should be as clean as any other water. The chlorination should be there. Municipal supply should be filtered, filtration and chlorination and proper treatment and safe drinking water in the tap and environmental sanitation. Environmental sanitation also can contaminate if you don't have proper sewage disposal, if you don't have proper waste disposal, it may contaminate the water supplies, water lines. Then it may attract rodents also. And as I said, the salmonellosis is very prevalent where the environmental sanitation is poor and a lot of rodents are there and their excreta contains the salmonella, typhimurium or cholera suis, which causes diarrhea with sometimes fever and occasionally blood. Then, of course, secondary prevention is to reduce disease severity. Primary prevention, so continue breastfeeding and vitamin A supplementation. Vitamin A also it helps in immunity and the epithelium, corneal epithelium and perhaps intestinal epithelium. Because vitamin A deficiency there, the diarrhea also. Treatment of episodes of acute diarrhea with zinc. Zinc also is one of the important in the secondary prevention. And of course, oral rehydration therapy, which should be taught to the mothers. The oral, different forms of oral rehydration can be developed by at home. So these are home. Simple solutions can save children's life. This is an important message. The integrated global action plan for the prevention and control of pneumonia and diarrhea. These are two major causes of child deaths in developing countries. So this is the actually charge pictorially. The first is prevent. Prevent is by the safe water, hygiene, sanitation, other things. Then protect. Protect is by uh, frequent, by good nutrition, adequate breastfeeding, measles vaccine, say maybe rotavirus vaccine, or and reduce pneumonia and diarrhea morbidity and morbidity by early treatment. The auxiliary health workers at the periphery should be able to start the ORS at least and identify the child who is severely dehydrated, en route continue the ORS and to a health center. And of course, for pneumonia, also the same thing. You can, by the respiratory rate, one can make out the protective intervention. Provide the foundation of children healthy and free of exclusive breastfeeding. That is, first 6 months, not even water is to be given, and without additional fluids or liquids, including protects infects for disease that is well known. All diarrhea episodes and one-third of all respiratory infections could be prevented with increased breastfeeding in low and middle. So even respiratory infections can be prevented with increased breastfeeding. So this is an example because nowadays there are social changes where the mothers are working. So this is an Australian Senator, Larissa Waters, has become the first politician to breastfeed in the nation's parliament. So the offices, the mother-friendly offices should provide breastfeeding intervals or breastfeeding space so they can bring the infant and they can breastfeed in the office. So these are just examples as a role model, but of course it is easier said than done. But this is a challenge we should try to adequate complementary feeding. And as the child grows after 6 months, the top feeding and solid introduction of solid food, that is the crucial time again from 6 months to 2 years. Adequate quantities of safe, nutritious, and age appropriate foods alongside continued breastfeeding. And this food has to be prepared hygienically. Here, the awareness of mothers in hygiene, availability of soap, and proper cleaning of utensils and surroundings are important. This can reduce child death, including those due to pneumonia and diarrhea. Vitamin A supplementation is also important. High dose vitamin A helps maintain strong immune system and can reduce cases of diarrhea by 15%. Children between age of 6 to 69 months should be protected with two high dose supplements of vitamin A every year in countries with high under 5 mortality or where vitamin A deficiency is a public health problem, which can be done by Betot spots and all those surveys are done. Unsafe drinking water, this is the main aim, and poor hygiene and sanitation. Hand washing with soap alone can cut the risk of diarrhea at least 40% and significantly lower the risk of respiratory infection also. You see, hand washing you must have seen during the COVID times. They used to, everybody was washing hands and the sanitizer. But just soap and water hand washing is adequate, particularly before food and after. Clean home environment and good hygiene are important for. So these are again challenges because poor people don't overcrowded conditions, many children. So these are, of course, that's why the standard of living, poverty, these are the main issues which require addressing. Safe drinking water and proper disposal of human waste, including child feces, are vital to spread of diarrhea. So these are again challenges in crowded conditions, slum conditions, tenements. There are no places for and safe drinking water also should be priority because the middle class is using bottled water, but the poor class is dependent on tap water. And if they use buy the bottle, they will be taking away from nutrition, money from nutrition. So it's a so these are the recommended treatment for this is a homemade solutions can be made and the easily available packets in health centers are available. WHO ORS packets which contain the sodium, bicarbonate, potassium, glucose, and 1 liter of water. So according to the instructions, it should be prepared. That again requires demonstration to the mother. For making oral rehydration salt. So it can be like if the packet is not there, improvised can be made. This is like mother can be given demonstration how to even if a child comes to hospital, you treat the child is okay. At the time of discharge, the mother can be given this awareness that in the next episode when because as I said, if the conditions are same, the child will again get So initially the mother should be able to start. So ORS and clean water, 1 liter drinking water, in that half teaspoon of table salt and 2 teaspoons of sugar. Salt and sugar completely dissolved. So this salt and sugar solution also is a good electrolyte which can be prepared at home. So this is which can be explained to the mother by demonstration, half a spoon, because if the mother doesn't have good comprehension or literacy, so mother's literacy itself brings down the rate of child mortality. So these are some of the how to calculate depending on the child, and every few minutes signs of dehydration until you are no longer shown signs of dehydration. Being able to pass urine. If the child adult passes urine, that is a sign that you are dehydration. You are gradually taking care of your dehydration, and now you may reduce the intake. Alternative doses, babies under 2 years can drink half liter ORS per day. Children 10 years can drink 1 liter of ORS per day, and children over 10 years and adults can drink 3 liters of ORS per day, depending on the number of stools, uh, because you have to avoid overload. Above 10 years, 3 liters per day, and below 2 years, half liter, and under 10 years, 1 liter. So it is just a rule of thumb. So this is, of course, this is every 5 minutes, 100 ml every 5 minutes. If you are passing stools. Use of oral reagents, salts and zinc are proven and affordable treatment that helps prevent diarrhea deaths among children is too low, particularly use is low here. They have done surveys. We had also done surveys few years back, I think 4 5 years back. In our survey, we found only 35% of mothers were giving this home-based ORS to children, to the children who are having loose motions or diarrhea. And they have done studies in Africa also, and they have found less than 50% oral rehydration. So these are some of the studies. These are 2012 and 2022. Over the 10 years, there was only marginal increase for 40-45% to around 50%. In different countries are there, I think. So there is still it is less than 50% or just 50%. But the 50% of the mothers are not giving ORS. This is a study in 2022. 2012, the black is 2000, darker one is 2012, and this lighter one is 2022. So over 10 years, there is hardly we are not able to reach the mothers. That means in 10 years, in a decade, we have just marginally increased the use of ORS. So this is something which nurse practitioners can help, or other health workers can help. Doctors may not have time to explain to the mothers. So we are, or even ASA workers or Anganwadi workers can take on the job. So use of proven affordable treatment. And so this is David Morley. He was the one who worked almost all his professional life in Africa, and he developed the Road to Health card. And these are the simple measures: how to control measles vaccination, how to treat diarrhea, how to monitor the growth chart. So he is the pioneer, David Morley. He wrote the book Pediatric Priorities in the Developing World. It's a beautiful book. It's a very old book, but it has got a lot of messages which can apply even today in developing countries. And he says most of the population is in rural, doctors are in urban areas, which is a problem in our country presently. So where he took research, and this is about low-cost health initiatives and agencies globally. So these are some of the references. As I said, these are some diarrhea recent references from Africa. I think that's all. Thank you so much. I think I can take some questions. I can stop sharing.
Thank you, sir. Thank you so much for the comprehensive talk. It was really very informative. So thank you so much, sir.
Thank you.
Yeah, we have received few questions, sir, from the participants. So with all your permission, I'm sharing my
Yeah,
screen, sir.
please.
Yeah, thank you, sir. So, here is the first question.
Severe reaction. As I said, one has to be only careful uh, when the child is under severe acute malnutrition. Severe, and just a plain adult or a plain child with severe dehydration, you can start oral rehydration fluid, and if the patient is taking oral rehydration well, and you can continue till there is proper urine output and the signs of dehydration like dry tongue and others. And if the patient is very severe, like the child is in stuporous coma, can't even breastfeed, then or the adult where there is fall in BP, very high fluid depletion, hypotension, severe hypotension, the child or the adult may require intravenous rehydration, IV rehydration, hospitalization and IV fluids, lactate or single lactate or even the IV rehydration fluids are available. So this is the, yeah, but if you have started early, oral rehydration started early, there should be no requirement of IV fluids, and before it can be managed in the community with oral fluids. And this was discovered in the 70s, I think, or 80s, in cholera epidemic in Bangladesh. And they identified this as the seat anchor of treatment, oral rehydration solution, ORS, which was um, also labeled as the discovery of the century or discovery of the decade. So this is a it's a simple thing, but usually simple things are difficult to, as we saw, the 50%, less than 50% of mothers are aware of it, that this can save lives. So this is the most effective approach. If you ask me, fluid and electrolyte management is ready-made packets are available. WHO ORS packets are available. Commercial packets are also available, which are, you have to give in 1 liter water, or you follow the instructions. Glass of water, it may be a smaller packet or smaller, and stick to that what is given in the instructions, and that is the most effective. Common variable. So it's a multiple factors are there. Immune regulation, they can be like the gut. Gut is the exposed to the environment. Like or respiratory epithelium is exposed to the respiratory viruses or respiratory. Similarly, the gut is exposed to the environment. So day in and day out, there are challenges where the local immunity, IgA and other things, can ward off the many pathogens. It acts as a first immune barrier. And besides that, it starts with the stomach. We have got gastric acid, HCl, that also can take care of many. And then, of course, the gut is the, like, it has got its own set of immune mechanisms. Lymph nodes are there, epithelium is there, and so anything which causes immune deficiency will affect the local immunity of the gut. That's why in HIV infection, in AIDS, diarrhea, prolonged diarrhea beyond 14 days is one of the signs, because it's an immune deficiency. So they are IgA, mostly it is local immunity, IgA, IgE, these are the which are any immune dysregulation of this local antibodies, and other lymphatics in the gut. You know, in typhoid, they are the Peyer's patches. which are sort of a defensive mechanism. They get the lymphatics of the gut. So it's all in, it's linked with your immune system. Gut has got a strong immune system. And the microbiome also, that also is coming up in a big way. So these are all things which are, these are very, you're asking questions which are the domain of the gastroenterologist. And that is if you are not able to control the diarrhea, uh, approach to diarrhea. So this is acute diarrhea. If acute diarrhea, it should resolve soon, within a week. And if it is prolonged beyond 14 days, then all these things may be required. What are the advanced imaging techniques? Before MRI, you can have an endoscopy, colonoscopy. They can be in elderly, it can be malignancy, you have to rule out. So it requires a referral to a specialist. So management, and then according to the specialist, uh, they will decide which. So just blindly, you do not push patients to MRI and all. Unnecessarily cost is there, and it may not be the relevant investigation. You go by stages. First, try to manage. If it is acute, it will resolve. If it is not acute, you look for other causes, immune deficiency. Then if it is not that, then you, depending on the age and all elderly, you have to exclude malignancy. So all those things are the domain of the specialist and the super specialist. Unfortunately, nowadays the patients are directly asking without going through this channel. Then they are wasting money on unnecessary investigation. So that should not be there. These are very, what are the emerging therapies in this context? So this can be quite challenging. The gut-brain axis is also there, your neurotransmitters and the microbiome also, they say. And inflammatory bowel syndrome is also can sometimes become very challenging and may have some psychosomatic element, but it is a genuine problem for the sufferers. Sometimes they do some resection of the intestine also. So it's again, it is a domain of the gastroenterologist. So this is a chronic condition. Inflammatory bowel syndrome is a chronic. They are microbiome. Other things also have been implicated, but nothing is very certain, and there may be a lot of individual variations. So these are again domain of the gastroenterologist.
Thank you
Thank
so
you.
much, sir. Thank you so much for answering all the queries. And I would also like to thank all the participating doctors also. And I would like to request you all to follow us on Facebook, Twitter, LinkedIn, and Instagram for more medical updates. Thank you so once again for your valuable time and
Thank
for
you.
being with us. Thank you, sir.
Thank
With
you.
all your
Thank you.
permission, I'm closing the session over here first.
Thank you.
Thank you, sir.
I'm
Good night.
switching. Thank you.